For decades, warfarin has been used worldwide to lower the risk of harmful blood clots. However, its need for routine monitoring has led to the emergence of more convenient new oral anticoagulants. So what are these new drugs, and how do they overcome warfarin's need for monitoring due to its need for bridging therapy, unstable pharmacokinetic profile, and its various food and drug interactions? Warfarin and NOACs both inhibit the coagulation cascade, but differ in their targets. Warfarin antagonizes a protein-enzyme complex which aids in the regeneration of vitamin K. As vitamin K is involved in the activation of certain coagulation factors, warfarin therefore indirectly inhibits thrombus formation via the coagulation cascade. Warfarin has a slow onset of action due to the long elimination half-life of already active coagulation factors in the blood before administration. The requirement of bridging therapy with fast-acting heparin is not only invasive but increases the risk of bleeding. NOAC's mechanism of action overcomes the limitation. They function by two different mechanisms. Factor Xa inhibitors such as apixaban and rivaroxaban directly inhibit the enzyme responsible for thrombin formation. Others are direct thrombin inhibitors such as dabigatran, which acts by allosterically antagonizing the factor thrombin, thereby inhibiting the formation of fibrin and a thrombus down the cascade. Because NOACs are directly inhibiting functioning factors already circulating in the system, the onset of action is more rapid and no bridging therapy is required. A drug's effect on the body's intensity of coagulation is measured by INR. Warfarin has a narrow therapeutic range, so if INR falls even slightly out of range, there is an increased risk of clotting or bleeding. Because warfarin has an unstable profile and a high tendency for food and drug interactions, its efficacy in vivo needs constant monitoring. An extensive list of food and herbs are cautioned during warfarin use, as its efficacy relies on low vitamin K levels. As NOACs function independently from vitamin K, they have little to no food restrictions. Drug interactions are a major problem with warfarin use. Warfarin is primarily metabolized by hepatic cytochrome enzymes. These enzymes are also a target for antibiotics, antiarrhythmics, and even grapefruit juice, which can inhibit their action, thereby increasing the effect of warfarin and the potential risk of hemorrhage. Factor Xa inhibitors, however, are metabolized by less hepatic enzymes than warfarin, therefore have less potential for drug interactions. The direct thrombin inhibitor dabigatran is unique, as it is metabolized from a prodrug by only nonspecific esterases and excreted unchanged, therefore is completely immune from drug interactions involving CYP enzymes. Both types of NOACs are substrates for P-glycoproteins, which play a big role in excreting NOACs into the intestine, bile, and urine. Potent PGP inhibitors or inducers shouldn't be used with NOACs, as they can affect drug bioavailability and excretion, shown by changes in INR.
So with all these pharmacologic advantages, why don't we ultimately replace warfarin with NOAC?
It's because they're still relatively new, and usage is currently limited to contexts which have been shown to be effective in trials and TGA approved.
Then when should we use NOACs?
NOACs are effective in patients with non-valvular atrial fibrillation, and when compared to warfarin, trials show a significant reduction in the risk of intracranial hemorrhage. A few other contexts have been approved for NOAC usage, but with certain provisions. While all three NOACs are effective for the primary prophylaxis of venous thromboembolism, approval is limited to elective knee and hip surgery. Only rivaroxaban has been approved for treating deep vein thrombosis and pulmonary embolisms, but is not recommended for high-risk patients. The convenience NOACs promise should not overshadow their many limitations. Most trials testing the drug's efficacy for thromboprophylaxis excluded high-risk patients from their sample population. Therefore, warfarin is still the oral anticoagulant of choice in many clinical cases. Dabigatran was tested in patients with mechanical heart valves, but the study was discontinued because it caused increased bleeding complications compared to warfarin. A major disadvantage to keep in mind is that while NOAC antidotes are being trialed, none are currently approved for use. So in cases of overdose or life-threatening bleeding, NOACs are unreliable. Warfarin, however, can be reliably and easily reversed in as little as 4 to 6 hours by vitamin K or fresh plasma infusion. In addition, because NOACs are recent developments, they have no long-term studies on safety and efficacy, unlike warfarin, which has over 60 years of research backing it. So until further trials have been conducted on this promising new drug, The choice between new oral anticoagulants and warfarin should be made with a risk-to-benefit assessment by an informed healthcare professional.